So the topic for me today is pulmonary function tests and its importance for anesthesiologists. So what is my interest? Why do I want to do a PFT? So PFT otherwise is very time consuming. It's like when you ask for an PFT, it is not like easy as like getting an ABG. So what do I want to know is what is the severity of the disease? How severe it is? Is it giving me some time for optimization or not? If the severity is going to remain the same, then there is no point in going ahead and waiting for it. So I have to accept the patient whenever he is in that symptom-free period and try to give him some chest physiotherapy, which will optimize the patient. And it will also help me to decide the plan of anesthesia and whether this patient will need a post-operative care in form of an HDU and an ICU. Especially planning your pain relief procedures is very vital when it comes to chest involvement disease to this patient. Again, I need to have a post-operative pulmonary complications or a risk stratification. Yes, in today's world, we have to explain the patient what is happening, what is he undergoing, the relatives as well, whether he will be needing post-operative ventilator in this patient, yes or no. Do they have to put extra money? Yes, once I say 1 day of ICU, 2 day of ICU, going on post-operatively on ventilator, everything will count in terms of money. And lung reduction surgeries, we know it is impossible to decide whether some portion of the lung can be removed safely so that the patient can survive post-operatively. And the cost and risk involved, everything revolves around money today. So the cost in terms of whether if it gives me a certain important value after doing this, and the risk, because most of this, as you see, PFT has a lot of contraindications also. No, most of the patients who we want in PFT who have developed post-operative MI, who are having breathlessness, signs of heart failure, advanced pregnancy. All these patients are relative contraindications for PFT. Again, the cost for patients who are diagnosed of having a respiratory element must be undergoing PFT every yearly. So how really does it, am I justified to ask for a repeat PFT immediately if he has once per year, 3 weekly, or just if it has been 3 weekly, or should I go on symptom basis? Of course, you need to involve the speciality into this. A pulmonologist will also guide us with this. But all these things I have to keep in mind when I'm asking for a PFT. So this is how a PFT report looks like. Why is it important? Because most of the PFT, it varies, the normal values varies with age, sex, race, and ethnicity. So what does a PFT report gives me is this is the set of values, the patient's value, the predicted value for it, the percentage of the predicted, and the post bronchodilation value. So this is what we are looking today. But nowadays, if you go to the Western world or the European world as well, they have set changed this to LLN, the lower limit of normal and the Z score. So they are seeing how much deviation it has from the normal, but that is still not accepted in India. Most of them are following the old method because we don't have those normal values depending for the age, sex, and race to the Indian population. So we are continuing using the same. As you see, any PFT, you will see at least 2 to 3 loops or volumes. So that is because we have to see whether there is reproducible. So if it is reproducible, only then they accept. So generally they take three. So three same loops is taken as normal and acceptable. So there should not be any coughing. Looking at the graph, it should be okay. Again, the expiratory volume time, if it is less than 1 second, 2 seconds, then they don't accept it. It should be at least more than 4 seconds. So, and then especially in COPD patients, you can have it as long as 10 seconds also. So, looking at the glance of the low volume loop, looking at the expiratory time it requires, that also gives you an easy diagnosis ki what is going wrong. And even if we can compare these things and not going into the depth, just looking at the graph tells you many things. So initially we were doing PFTs in terms of FEV1, FVC, where we are expiring. It's a forced expiratory volumes were taken. But nowadays we also commonly do your total lung capacity, your FRC, or the expiratory reserve volume by a body plethysmography, which works on your simple Boyle's principle. Again, the dynamic lung volumes and flow rate also involves your diffusion test. Your diffusion test will tell you whether the pulmonary capillary exchange is good or not. So this is generally how a PFT report looks like. Of course, the report is also seen by the pulmonologist who gives you an interpretation. So that helps too. So mechanically, your PFT has three components. One is mechanical, a parenchymal, and a cardiorespiratory element. So mechanical, you have the static lung volumes. which involves your basic PFT, your FEV1, your dynamic lung volumes, where you are asking the patient to forcefully expire and take inspiration, and you see whether the conducting airway is normal or not. And initially, in older days, the bedside PFTs were done. The parenchymal function is assessed by your diffusion lung capacity using carbon monoxide, and your, of course, by your arterial blood gas shows you about the PO2, PCO2, and the alveolo-atrial gradient. But nowadays, the most popular of this segment is the cardiorespiratory test, which we do the functional analysis. That is the cardiopulmonary test by doing a 6-minute walk test, which is again very commonly done, a shuttle test, and the cardiopulmonary exercise test, which is a very sophisticated test involving multiple parameters, your blood pressure, pulse oximetry, you're doing an exercise, sitting on a treadmill or a cycle, and it is a proper room in a sophisticated. Most of the bigger hospitals do have this facility, which gives you a proper integrated analysis of your lung, heart, and the muscle. So, of all those lung volumes capacities, what is important for the anesthesiologist is the functional residual capacity. We all are big fan of functional residual capacity. So, what does it tell me, FRC? By we all know the moment the patient lies supine, the FRC is dropped by a liter or less, around 800 ml. So mostly we always have, it was a school book of thought, or you must have seen the old anesthesiologists. They always prefer to give a little head up. Just a 15-degree head up will also improve your FRC by nearly 30%, and it will help you to have a better oxygenation. And this better oxygenation or the pre-oxygenation, we all know, we are all big fan of apnea time, and we always want to buy this extra apnea time, especially in your difficult intubation where you are anticipating difficult intubation, your obese patients, some airway pathology. We always want to pre-oxygenate this patient and help in your increasing your apnea time. General anesthesia, by virtue of your muscle relaxation and diaphragm paralysis, the FRC drops by 500 ml around, which is taken care by a positive pressure ventilation and sometimes by giving an extra PEEP. As the FRC approaches the closing capacity, as we know at particular, this a small airway starts collapsing and there is an atelectasis, and consequently hypoxia can be seen, especially happens, which is a very common phenomenon in this obese patients. So in them again, this FRC will drop and we have to enhance this FRC. Even in pregnancy, the last stages, twin pregnancy, PIH, cardiac failure, all these patients can have drop in FRC. Pain is very important. The fifth vital sign has to be taken care so that adequate breathing is done by the patient post-operatively, and that should not reduces FRC. So the other lung volume and capacities which we see, which displays the flow resistive property of the airways, the force vital capacity, the vital capacity, the FEV1 by FVC ratio, then your force expiratory flow rate, all these are plotted against the flow against the time graph. So it tells you about the resistance of generally the resistance for the property of the airway. The vital capacity, it is affected by factors that limit both. You know, it is done by you have to, after a regular expiration, you have to maximally inspire and then forcefully expire. So both factors can limit it. Again, vital capacity, we all know 2 to 3 vital capacity breath is known to hasten pre-oxygenation, which as normal tidal volume would be go on for 2 to 3 minutes. So where you want to immediately induce this patient or you have no time, there is fetal distress, we all would like to use this vital capacity breathing to enhance oxygenation. Again, FE1 FVC ratio less than 70% is used for many diagnostic criteria of your obstructive versus restrictive disease. And then post-op ventilation, if the FVC is less than 20 ml per kg or your FEV1 is less than 15 ml per kg, look at these values. They are very important. That these are the patients who can likely go need post-operative ventilation. So for these patients, you cannot have some, it's very common in our government setups where we have some ventilator somewhere, ventilator standby. No, it won't work here. We want the ventilator, a working ventilator, and a properly patient into should go in a ICU setup. You cannot have some ventilator standby for such bad PFT patients. Then your MVV and MBC, this also parallels FEV1 because it is taken over the maximum multiplied by rate. So it is multiplied, FEV1 multiplied by rate will give you the maximum voluntary, the breathing capacity. So it also, what are we checking with MVV or MBC is also the pulmonary musculature strength. So especially in your neuromuscular disease or your GB syndrome, these patients will, initially they may have all these normal values, but the MVV, MBC will be showing a lower grade or will be on the downtrend. Again, I searched a lot of internet to reach to a value like something. Is there some norma which tells me that this patient has inadequate PFTs for anesthesia? So there is nothing like that which literature quotes. So we always take a reference, right? So I asked my colleagues in chest medicine as what do they look in when they can say, this patient is not safe for anesthesia. So this is one vital thing. MVV, MBC, anything less than 50%. Generally, these patients can be very difficult to get them out of ventilator and have a long course into ICU. Again, the post-expiratory flow rate, your maximum inspiratory pressure and maximum expiratory pressure, which ranges from minus 80 to plus 80 or 100 centimeters. And it is also tells you about the muscle strength and the maximum flow. These values can be just taken in 0.1 second and it judges the ability to cough. So anything less than 200, your PEFR less than 200 ml per kg per liter has an impaired cough reflex. So such patients will need some tracheal toileting postoperatively, some methods, or you may need to have other methods, or you need to put in the tube maybe or through a tracheostomy maybe to help in tracheal toileting. And this is also, they are one of the important predictors of your postoperative pulmonary complications. Your MIP and MEP are early predictors of muscular pathology. Yes, so especially in your diaphragm paralysis, if you are doing some cervical spine surgery and there is a diaphragm paralysis and you have a PFT done where MIP and MEP was normal before, and post-operatively a patient claims case this is destruction and breathing difficulties due to some surgical injury, then they can put up a medical legal case and this would can prove that this was then happened during surgery. Okay, so another is the cardiopulmonary reserve. So this is very important and one of the actually very physiological. So 6-minute walk test is most of the commonest test. What we do, we also do it in a regular pre-operative checkup nowadays. So it is just what they do is we have to have a path to walk and we should know how much distance. So you ask the patient to walk and see how much distance is it covering in 6 minutes. So the distance covered in meters by 30 will roughly give you the VO2 max value. So the other common test is what there is shuttle test. So there are two cones which are 10 meters apart, and here the intensity of your walking increases with your every shuttle. So if you're walking anything less than 2000 feet in your 6-minute walk test, if the distance is less than 250 meters in shuttle test, that is inadequate or your VO2 max is low. And if there is drop of SpO2 of more than 4%, you have to check a preoperative SpO2 and then check it again after this test. If there is drop by 4%, that is a significant loss and you have a low VO2 max. So anything less than 15 is patient can have high chances of postoperative pulmonary complications. And if it drops to 10, then it is very high. So probably this patient is not fit for your anesthesia or going. So you need to talk with this patients and probably this patient may need some staging or optimization before you take him. And this is a proper cardiopulmonary exercise testing which is done. So you have all the parameters is in place and the test is also read like according to the age wise and it is rated as per good, excellent. So they drop in and see what is your VO2 max. So your FEV1, FVC. So this is the very important or the hero of the entire PFT. So even looking at the curve or the graph, it will tell you whether it is obstructive or restrictive. So what happens in obstructive lung disease is the airway obstruction causes airway closure of the airway and so air trapping occurs and it affects the expiratory limb. So you can see the scooping here in the expiratory limb. While as in restrictive, it is just a miniature form of the normal curve. Here all the parameters have reduced. So the curve is just taking a smaller appearing normal curve. So it's in obstructive disease, the residual volume, the FRC and the RVTLC increases. While in restrictive, since the lung is only shrunken and everything is reduced, the ratio remains normal, but all the capacities are. So in FEV1, the FEVC ratio, everything is reduced in obstructive pattern, while here the ratio is maintained. So why this is important? The FE1, FEC may be normal, but the graph, the scooping can occur earlier. So large airway obstruction typically affect the peak flow rate and small expiratory with long concave shape indicates a small airway disease. So looking at the graph only, you can come to know what you are dealing with. Again, even this graph helps us to know whether there is any obstruction in the airway, especially your extra variable thoracic obstruction. So when there is an extra variable thoracic obstruction, the inspiratory limb gets affected. So during a forceful inspiration, a pressure gradient is created which will collapse the airway, especially when there is unilateral vocal cord palsy, proximal tracheomalacia, or obstructive sleep apnea. While when there is an intrathoracic obstruction, so what happens during forceful expiration, the pleural pressure is more than the intraluminal pressure, and there is collapse during throwing out of the air. And so this will be seen in distal tracheomalacia, tumors of trachea, and main bronchus. While in fixed obstruction, this is the anatomical caliber of the airway which is causing a problem and not the dynamicity of the airflow. So you see both the truncated part in the inspiration and the expiration, which you see in tracheal stenosis, stricture, bilateral vocal cord palsy, or goiter. So now again coming to COPD, yes, the gold criteria is what is most popular and we are using it in everyday today to help. So this global initiative of chronic obstructive disease have said it is recommended that every patient who has been diagnosed with COPD should undergo a PFT. So this spirometrically they confirm the diagnosis. They assess how much is the airflow obstruction. They also assess the symptoms and risk. Then they see what is post bronchodilator FEV1. Accordingly, the FEV1 they are staged into gold 1 to gold 4. And according to the staging and their symptoms and number of exacerbations they have or hospitalization they have, accordingly, the treatment is given to them depending upon the category. So it becomes very easy to prognosticate such patient when it comes to us, whether he was in gold one and gone into gold and how much time duration has it taken and how much is the reversibility. And again, the incidence of postoperative pulmonary complications, many studies have proved it parallels the severity of respiratory impairment. So lesser the FEV1, more are the chances of PPCs. Again, the residual volume is generally the first volume which is going to rise here. So suppose patient who is symptomatic and the residual volume is started to rise. So probably looking at that residual volume will also tell you about the air trapping. And this air trapping in respiratory medicine, it also predicts mortality. So RV-TLC ratio, anything more than 40% is diagnosed as hyperinflation. So we are all very fond of doing ABG. We are very comfortable doing an ABG in over reading and PFT. Even myself, I always like to see what is PO2, PCO2, pH is maintained, not maintained. So I was trying to search on something, which can correlate this FEV1 with your PO2 and PCO2. Unfortunately, there is only one study. And what did they see? And this was done in all COPD patients with acute exacerbation. So the PO2 was nearly normal till the FEV1 was seen as 50% of the predicted, while PCO2 was only rising after the FEV1 was up to 35 to 25% around. Again, this all the COPD patients who are coming to ICU. There was another one article where ICU where they wanted how frequently you should do an ABG for some such patients. So generally they are saying like the FEV drops around 35 to 40%. So probably you should then prick their arteries because if the patient is on oxygen support at home, so taking the ABG in such patients, pricking the artery is not wiser. So they did a study which showed, when it reaches up to the 40% of your FEV1, you should go and pick one ABG. Again, you have this obstructive pattern, normalization of the spirometry of the bronchodilator supports the diagnosis of asthma. So generally, there is an improvement of 12% in FEV1 or FVC by 200 ml. So it is diagnostic. So you do a PFT and there is reversibility, that is asthma. So concavity of the loop indicates airway obstruction, and that can be seen prior the changes in FEV1, FVC occurs. So what do you think FEV1 tells you about therapy optimization? Because what happens is they will give you this bronchodilators. If there is improvement in the graph for FEV1, looking at the FEV1 value, they will know whether the patient is taking this inhalation or inhalers well or not. Are they using those spacers well or not? Or they need nebulizations and not those spacers. It will also have a prognostic value. So FEV1 dropping FEV1, like we do it this year, FEV1 was 60%, now it has dropped to 50%. So okay, probably it is going bad. And reversibility, of course. So low FEV1, the risk of asthmatic attacks and the incidence of hospitalization is higher. So what do you do when there is a reversibility? So I'm very happy that I get a report where there is a reversibility. So what do? I can add up short-acting beta-agonist inhalers with oral steroids for 4 to 5 days for the clinical improvement with their regular therapy. And then thoracic anesthesia. PFT is the crux here. So what do we want to know in thoracic anesthesia and anesthesia? How much segment of the lung can I remove so that the patient is post-operatively able to maintain CO2 washout and oxygenation of the body? That is what I want to know before taking this patient on the table. So what I do is I have a disease lung. So generally the pulmonologist, thoracic surgeon, and anesthesiologist all are doing this together. So we calculate what is the predicted post-operative FEV1. So pre-operative FEV1 into number of segments which will be left after the resection upon 19, or sometimes if they're doing a sub-segments are also counted, so it comes to 42. So what is the FEV1? Post-operative predicted FEV1 is less than 30 to 40% or DLCO 30 to 40%. So these patients are at increased risk, or VO2 max less than 15 ml per kg per minute. These are more risk. So if you have an FEV1 which is more than 1.6, you can do a lobectomy. If more than 2 liters, you can do a pneumonectomy. So what do you do is first you see whether the functional capacity of the patient it is less than 2 minutes or more than 2 minutes. If it is more than 2 minutes, you do a spirometry. See what is the post-operative predictive FEV1 and post-operative predictive DLCO of this patient. If both are more than 60%, you can go for the scheduled pulmonary resection. If it is either 60% to 30%, do a simple exercise testing, like a 6-minute walk test. If he is able to walk 100 meters, you can go for the surgery. If it is less, then you should either, if this of the any two of these values are less than 30%, then you should do a cardiopulmonary exercise testing, and we should know what is the VO2 max. If the VO2 max is more than or equal to 10 ml per kg per minute, there is increased risk of scheduled pulmonary resection, and some alternative have to be. So we have to inform the patient about it. And if the VO2 max is more than 10, if it is less than 10, you have to do high risk, and probably you cannot do a pneumonectomy, and you have to do something else for this patient, or you have to explain it to the relatives. So that is very important. So in kyphoscoliosis, so this is the three-legged approach which we do. So we see the functional capacity, a spirometry, and a cardiopulmonary exercise testing. All three is to be done. So in kyphoscoliosis, this is one complex surgery requiring anesthesia, complex pulmonary function, and a prolonged surgery as well. So generally we see a restrictive or a mixed component depending upon the pathology and the age of onset, whether it was congenital, post-tuberculosis. If it is post-tuberculosis, after 8 years, lung development has happened completely. So generally, sometimes those are spared. So we always see how much is the Cobb's angle. So the degree of the thoracic curve has a negative correlation to FEV1. So more the thoracic curve angled, less will be the FEV1 and bad will be the patient. So generally, there are many studies which were done, or by the especially by the orthopedic people, as you know, where they had seen maximum reduction in the vital capacity. So any mid thoracic curve angle more than 60 generally has a bad lungs. So declining FVC or the forced vital capacity mandates surgery. Suppose we get a PFT report which is showing the forced vital capacity is declining. I cannot say optimize, give an advice, chest medicine review, optimize, start bronchodilators. No, probably if I declining is because of the primary pathology, the kyphoscoliosis. Why wait for 6 months or a year? Probably when this patient is going to put up, will be further bad and it will be further complex. Again, when you should also know what are they planning for this kyphoscoliotic surgery. As you can see here, it is very angulated. This is one which we did 6 months back, and this patient had come to us in ICU as well. So in this, thoracoplasty was also planned, which was not informed before. So this we should know. If the thoracoplasty is done, we should discuss it with the pulmonologist as well. It should be a teamwork, because suppose this patient had a moderate restrictive, the PFT had shown moderate restriction before, but post surgery it was very difficult. We had difficulties in weaning him off because they had removed 3 ribs. There was pain, so it took a longer time. So we should know whether thoracoplasty is done, whether the lung function is severe or moderate. So in such patients, probably you will have to do a stage surgery, or you may have to do a segmental instrumentation and not go for a complete rod. So all these things has to be decided. So in obesity and pregnancy, these are two places where we see the expiratory reserve volume and the FRC is dropped. In obesity, the is directly proportional to the body mass index, and the central obesity will affect the PFT more than the peripheral. And your forced expiratory flow volumes of 25% to 75 are the early indicators or respiratory complex. And you have this typical, sawtooth appearance on the expiratory limb, which is more suggestive of obstructive sleep apnea. So that is also looking at the loop. Also, you can say whether this patient has some component of OSA or not. And in pregnancy, so most of these pregnant patients, again, the due to elevation of the diaphragm and the stretching of the muscles, they will have this drop in FRC, especially at the gravida. So most of these patients are also tachypneic physiologically because they are pregnant, hormonal changes and all. So how do I identify what is pathological dyspnea? So any increase in respiratory rate, abnormal FEV1 and abnormal echo should be evaluated. Again, diaphragm paralysis are not very uncommon for us to see a diaphragm paralysis, and especially in post-trauma cervical injury patients. Post commonest is you give an interscalene block. We all know it is 99% association, but the phrenic nerve can get blocked. So if you have, it's a bad luck and you have an obese patient who is having a higher BMI, FRC is dropped. So if you give a block in such patient, they can have breathlessness during the because of the phrenic nerve palsy, because unilateral palsy itself can reduce 50%, the FVC by 50%. So what you need to do is observe this patient, give him a propped up position, allow the block to the effect to go over, just give her some CPAP if required, and things should settle. But we should be aware of this. And we should all know that probably, if there is an obese patient, you're giving a block of the cervical spine patient. So they need monitoring post-operatively as well. So again, bedside pulmonary function test, rather, we all as an anesthesiologist are doing this first. And if we find some pathology in this, then we are referring this patient for your conventional or your proper PFT. So generally, there are many to this number, so it's really difficult to cover. So what do they look for is what is the cough strength and pulse oximetry. So breath holding time, I think this is the most common and everyone is practicing. It is even a part of our PSC. We all have a BHT as a part of your pre-anesthesia sheet. So anything less than 15 seconds tells you the forced vital capacity is less than 2 liters and this patient is going to high risk, and then we send him for cardiopulmonary assessment. Again, the cough test. So it is, forced expiratory effort, which tells you whether the cough will come out or not. So anything less than 200 ml is poor. Patient will need some tracheal toileting assistance and have a bad postoperative pulmonary complications. Snyder's test, the right spirometry. So generally, they try to see your vital capacity or FEV1, and the forced expiratory flow rate is 4 to 5 times of will give you your MVC, and your MVV is 35 into FEV1. This is what all old people generally how they calculate, and they reach to whether it will cause postoperative pulmonary complications or not. So at the end, is there any PFT where there are PSC guidelines? No, no definitive guidelines are there in for your pre-anesthesia checkup should have a PFT. Rather, Miller, there is a statement which clearly states PFTs are not required to take a patient. You have to look for clinical symptoms and go ahead with the surgery. So there are few pre-anesthesia evaluation guidelines which are followed, where the pulmonary function test or spirometry should balance the risk and cost of this evaluation against their benefits. Again, characters I to consider include type of invasiveness of the procedure, especially abdominal surgeries or thoracic surgeries, interval for previous evaluation, treatment, whether symptomatic asthma or symptomatic COPD, scoliosis with restriction, you can be justified and asking for a PSC. So this is one article, probably pulmonary function test in anesthesia practice. There are very few. So they say abnormal PFTs may therefore be an indirect marker of PPC susceptibility, but cannot alone be used to quantify the risk. ASA 3 and 4 are best known. If they have a suspected respiratory disease, most of them will always be seen by a respiratory specialist and they may have an existing PFT. Then performing spirometry to diagnose and quantify the disease may be helpful, or new spirometry may be requested to seek evidence of recent infection that would affect the timing of surgery. Only then you should ask them for to do a repeat PFT. So in postoperative pulmonary complications is maximum if they are less than 50% of the predicted, your forced vital capacity, FEV1, MVV, and DLCO. If all these four are less than 50%, these are the chances where you can have higher incidence of postoperative complications, and air trapping, where the residual volume is increasing and the ratio is more than 50%. Again, these are the patients who will have most chances of going on postoperative ventilator care or physiotherapy. Thank you.